Welcome to Healthline 3. I'm Jade Balexa. Thousands are affected with cleft and craniofacial conditions each year in the U.S. And today we're taking a closer look during this special awareness month. And joining me now is Dr. G.E. Ghali. He is the director of the Oral and Maxillofacial Surgery Department at Willis-Knighton. Thank you so much, Dr. Ghali, for being here today.
Thanks for having me, Jade.
Absolutely, yes. Well, we want to talk about cleft and cranial conditions. What are they?
Well, as we mentioned earlier, they're fairly common conditions. Fortunately, common, but still kind of rare in their occurrence. Overall, if you look at craniofacial and cleft deformities, they occur in about 1 in 700 births in the United States. As we mentioned earlier, in some parts of the world, they occur as common as 1 in 200 or 1 in 300 births. And what they are is basically a situation where while a child is being born and during the embryonic process and developmental process of the child developing within the womb, there is some type of defect that occurs in the failure of the lip to fully form, or the failure of the palate to fully form, or it could be even as large as failure of the entire face to form, or the eye sockets to come together. So there are variable degrees of this condition that can occur. Fortunately, most of them are very treatable, and most of them are restricted to simple clefts of the lip or the palate.
And we have some photos we want to share you brought in.
Sure.
And this is one of your patients.
Right, yes. This is little Gracie, and her family allowed us to share these photos with our community in Shreveport-Bossier, so that hopefully they can understand more about this condition. This is a fairly typical picture of a little girl that has a bilateral cleft of the lip, and it goes through the upper jawbone, and it goes all the way through the palate, all the way to the very back of the palate. What we would call a typical bilateral cleft lip and palate, a fairly common form of what we would call a craniofacial condition.
Okay.
Right, and so this
is after the surgery?
Yes, ma'am. This is after the surgery with the lip and the nose repaired. And what Gracie has are some stitches that are holding a little conformer for her nose. And this surgery, the very first surgery, is done when they're approximately 4 months of age. And so a typical cleft child will undergo somewhere between a minimum of maybe 6 operations to a maximum of maybe 12 or more surgeries. So it's really quite variable. We're very lucky with Gracie's family because they're very caring and they take good care of her, and it's so very important. Here you can kind of see sort of about the same time. This is soon after the repair of the lip, and you know, the lip is a very complex organ, as you can imagine, and you know, when we're taking care of these children, we're very blessed to be able to take care of these children, that their families and their parents and their grandparents and their aunts and uncles let us take care of them, because it's really an honor to treat these kids. And it's so important because, you know, this is a part of the body, sort of like when we talked before about oral cancer and how it affects the mouth and the head and neck area. These clefts really affect their ability to smile, to kiss, to drink, to eat, to talk.
So it's not just about appearance.
Oh, I mean, absolutely not, yes.
These are about other factors as well.
Right. And this is actually a photograph of Gracie and I Soon after we did one of her surgeries, this was probably surgery number 3 or 4 for her, or maybe 4 or 5, where we do a bone grafting procedure to reconstruct a portion of the upper jaw. What's really important is just the multidisciplinary or the interdisciplinary approach to the management, just like in cancer patients that require the radiation oncologist and the surgeon and the medical oncologist and the nurses. These children also require an interdisciplinary or multidisciplinary approach in their management. Got to have a pediatric dentist, got to have an orthodontist, got to have a surgeon of some sort, got to have an ear, nose, and throat doctor that's going to be able to take care of their hearing, because hearing is also affected with these clefts.
Wow.
Yeah. Right.
So a lot of specialized care is involved.
Yes, ma'am, for sure.
So how old is she here?
Oh gosh, she must be in her just in her preteens right here. And this is a fairly recent photograph of her, and beautiful young lady.
Yeah, really remarkable, all the progress she has made and the work that you've done.
Well, it's a team effort, and like I said, it's very satisfying and we're very honored to be able to take care of these young folks.
Yeah,
for
well,
sure.
Thank you to her family for sharing these photos and letting us know the details of her life and the procedures she's had, because
right.
That's a lot to go through, for sure. But just really good to see everything.
Yeah,
that,
one of the things to sort of remember, again, and I keep sort of mentioning the team approach and to the management of these children. It really starts prenatally. When I was a resident 125 years ago, we didn't have some of the technology that we have nowadays, and nowadays we're really able to detect many of these clefts on ultrasonography before the babies are born. And so really at that point, you're able to counsel the family and to talk about things like, how are we going to feed them, how are we going to take care of them, and what type of activities are going to be involved right after they're born and around the time of surgery. So I think the advent of really high dimensional 3 and 4D ultrasonography has really helped in the prenatal diagnosis of these. And we don't really know what exactly causes clefts. In certain animal models and certain experiments and certain research that's been done over the years, certainly certain medications can cause a cleft in an animal model. It's never been fully proven in a human model, because nobody would do such type of research. But what we do know is the importance of prenatal evaluation and prenatal counseling and prenatal management of the mom. And so a lot of that really is involved in trying to reduce the overall incidence of clefting around the world. And of course, many of the countries that don't have good prenatal vitamins or malnutrition or things like this are the countries that we tend to see a higher incidence of clefting in.
Say that if people don't have the surgery on their babies,
Right.
as babies, as an adult, is it more difficult to have the surgery? I mean, is
Later
it best
on, yes.
to have the surgery?
It's best to treat these kids. Obviously, each child is individual. To treat them, typically the lip surgery is done somewhere around 3 to 4 months of age. Occasionally, we'll delay it till about 6 months of age. But really, the lip surgery should be done fairly early, somewhere between 3 and 6 months of age. and that reconstructs the muscle that goes around the mouth. So it's not just, as you mentioned correctly earlier, it's not just a cosmetic thing. Yes, obviously they look better, but you're actually functionally reconstructing the muscle around the mouth so they can speak properly, so they can take in fluids and things like that. Then typically most of these children also have a cleft that goes through their palate, through the roof of their mouth, through their hard or soft palate. That's a second surgery that's typically done somewhere between 10 and 18 months of age. Failure to do those surgeries really has a profoundly negative effect on their ability to speak, their ability to properly take in nutrition, and certainly there's an entire psychosocial component to it, whereby unfortunately, the world is cruel and tends to oftentimes poke at these type of situations, unfortunately. And so it's important also to consider their psychosocial development and to try to get the kids looking more normal, whatever normal happens to be, Mm-hmm. And it's interesting. We talk about what normal is, and I don't know. Every beauty is always in the eye of the beholder, and only the good Lord knows what's beautiful. But the one thing that's certain is that it's interesting. Sometimes some patients or some parents become reluctant to fix the cleft because they have gotten so used to this wide smile that their children, that their son or daughter has. But ultimately they understand that is the best thing to do for the child.
Mm-hmm. Exactly.
Yeah.
So, like the patient that we saw earlier, she successfully went through the surgeries. She's doing great from what it seems. Will she have to have any other surgeries, or will she go through life and not have any problems,
right.
with breathing, with hearing?
Yeah, well, those are all good questions. Typically, after the lip and the palate's repaired, oftentimes when the palate's repaired, we have the ear, nose, and throat doctors put in the hearing tubes and things like that in these patients, because you ever get your ears kind of clogged up, you kind of raise your palate or kind of swallow or do something like that to clear it up. Well, if you can imagine, if your palate's not working right because it has a cleft, then you're going to get dysfunction in your eustachian tube, and your pressure in your middle ear is not going to be right. So there's a lot of important, and speech is very much connected to hearing. So that's important. So yes, it's critical that hearing and speech and everything be evaluated. Surgery, like for Gracie, for example, what she may need in the future, it very much depends on her growth. If her jaws grow well, her upper jaw grows well. That's not uncommon in children that have had clefts, for their upper jaw to be retruded. Kind of, they have an underbite. If it's a very mild underbite, you can have an orthodontist just correct that with braces. If it's a more severe underbite, in that instance, they may also require jaw surgery. So that jaw surgery on these children would be counted as one of those 10 surgeries or so that they need, and that jaw surgery would typically be done when they're in their mid-teens. The very last thing that we typically do on these kiddos is do a rhinoplasty on their nose to get their nose straightened out. And that's typically done after all other surgeries are completed when they're approximately 16 plus years of age.
Okay.
Yeah, it's certainly a stepwise process. It's a huge commitment, and we owe a lot of the success to the families that are very vigilant and concentrated on this, as well as the multidisciplinary involvement of the teams.
Absolutely. Yeah. My goodness. So tell us about, is there any way to prevent the clefts or any of these cleft lips or palates or any other conditions like these? I mean, I know you said, it's hard to tell what causes them.
Yeah, it's hard to know what causes them. The cause of them is multifactorial, meaning nobody really knows. I can tell you that typically it's not, when we counsel families about clefts and when we see them, obviously they're very distraught, but we tell them it's really nothing that you ate or didn't eat, or drank or didn't drink, or smoked or didn't smoke. They just occur sporadically. There is also a genetic predisposition to it. And say, for example, if you look at the population in the U.S., about 1 in 700 live births are going to have a cleft. Once someone in that particular family has had a cleft, the incidence of the next child having a cleft is around 3%. Well, that means, there's a 97% chance they're not going to have a cleft, but there's a 3% chance, which is significantly higher than 1 in 700. So there is a bit of a genetic predisposition once a cleft has occurred in a particular family. That's pretty much it with that. I can tell you that if you look overall, the incidence of having one child, the next child having a cleft, as we mentioned, is 3%. If you have 2 children that have a cleft, the chance that the third one could have a cleft is somewhere between 10 to 15%, but still fairly low.
I was reading that maybe some medications, if a mother's pregnant, take some medications, like I was reading one in particular that people use for migraines. I think it was maybe like Topamax or something. Could that be a cause?
There has been quite a bit of studies done on various medications such as that, such as Dilantin and some of the anti-seizure medications. And some of these medications, at least in animal models, can induce a cleft in mice and other types of laboratory animals. But as far as in humans, there's been no statistically significant study that's shown that. Right. And so there's really nothing that the family can do to really prevent that. Now, there are a few, when this is Cleft and Craniofacial Awareness Month all over the United States, right? You mentioned that. Certainly with clefting, but with craniofacial conditions, there are a few craniofacial conditions that do have genetic markers that do run in families much more consistently than, say, clefting of the lip and palate. That's more of a sporadic occurrence. But there are certain craniofacial conditions where they do run in the family, and but still there's nothing you can particularly do to sort of prevent it from occurring.
This Awareness Month, what would you like people to know?
Well, I think what I would like them to know is that services are available in this community, and really in most of the major cities in the United States to appropriately and comprehensively, in an interdisciplinary and multidisciplinary fashion, to manage cleft conditions. I always tell families, they're distraught when they have a child, because they're just wondering, is this something I did? Is it something that we did? Oh my gosh, a lot of them say, I ask them, do you have any family history of clefting? They're like, oh no. Well, then it's true. Most don't have a family history with this. It just happens, sporadically. But what I do tell them, Jade, is that if this is the worst thing that ever happens to this child, they're going to be in great shape. Because not just me, but many surgeons around the country, many teams around the country are quite capable of comprehensively managing these children and giving them the most optimal opportunity to get a good cosmetic result, to get a good functional result, and to ultimately be able to contribute to society just as the good Lord would want.
Absolutely. So when we talk about like a team of care, Do you recommend the other doctors involved, or orthodontist, or how does that all work?
Well, certainly there's a team that has orthodontists that are on it, that has pediatric dentists that are on it, that have been part of the team for many years.
Because I would imagine they would have
Right.
to know a lot about
Correct.
cleft lip and
so
palate.
in a typical scenario, a team would meet either monthly or bi-monthly, where the entire group is present. And it requires, some of the craniofacial conditions are very complex conditions, and will require a child health specialist, will require a child behavioralist. So it's a very comprehensive type of team, and so yes, we recommend those. And then if there's people that aren't on our team, then we also have the ability, particularly through the Willis-Knighton system, we have the incredible ability to refer these children and their families to certain types of physical therapy, certain types of occupational therapy, certain types of audiology and speech language pathology, and many of these type of specialists that really, and Jay, very fortunate, because our town is not a huge town. We're not talking 2, 3, 4, 5 million people. We're a fairly small community, and to have the type of specialists that we do and the type of care that can be provided for these children is really remarkable in a town, fairly small town like Shreveport.
Yeah, we have a lot of good people here for sure. So what would you say, or could you describe one of your most challenging surgeries?
Well, the challenging is sort of depends on what your definition of challenging is. I don't think any parent wants to hear that I'm challenged by the surgery.
Yeah.
They want to think I just go in and woo, and do that. But every surgery is challenging for a different reason. We were talking the other day, just doing a reconstruction on a nose is even if you do, the surgeons that do nose jobs know how challenging that is. Well, it's even multitudes more challenging on a cleft patient, where you've got scarring from previous surgery, you've got asymmetry of the little cartilages of the nose, and you're sitting here trying to do that. That's a very challenging operation for sure. Probably the most challenging surgery, I think, are when we have children that are born that have their eye sockets that are wide apart. They have a craniofacial condition called frontonasal dysplasia, and they have, as a result, there's a condition called hypertelorism, where their eye sockets are far apart. And that operation requires, again, a multidisciplinary or interdisciplinary approach between the surgeon, the craniofacial surgeon, and the neurosurgeon. As well as a very competent anesthesia team and pediatric intensive care folks. And what's involved in that is taking the eye sockets and moving them closer together. Wow. It's a very three-dimensionally complex procedure, and that, I think, is probably one of the most challenging surgeries that we do.
Yeah, that sounds like it for sure.
It's a fun operation as a surgeon, but it is very challenging.
But what would we do without you? My goodness.
Oh, well, I won't answer that question.
Families need you. Wow, that is just so remarkable. So how can people get in touch with you if they have questions about everything we've been talking about?
Well, they can call our clinic, call our number through the Willis-Knighton Health System, and ask for the Department of Oral and Maxillofacial Surgery, and they can easily get a hold of us, get a hold of my secretary Jerry, Diane, Stephanie, any of our nurses, Claire. They're all available to talk to anyone, and you don't necessarily have to come to me, but you have another opinion, you need another opinion, we're more than happy to help with that.
Yeah, it's just amazing to me that you're able to see these kind of conditions on an ultrasound, you can see these things.
Right. I mean, the high risk OB doctors are fantastic nowadays. They can see things on ultrasound. Sometimes the cleft of the palate is difficult to see, but most of the lips also have a palate, and the lip cleft is very easy to see on a good high grade ultrasound. But see, that gives us the opportunity to meet with those families ahead of time and tell them that this is a manageable condition. How do we feed them? What do we do? How do we burp them? How do we do this?
Mm-hmm.
Man, you know, our nurses and our staff get them pretty much up to speed on that. Fortunately, we're very lucky in Shreveport-Bossier because the hospitals have very good nurses in the nursery and in the pediatric intensive care units, the NICUs. So we're very fortunate. Again, we're very fortunate in Shreveport to have what we have from a medical community standpoint. Very, very proud of our community and their support of medical care here in Shreveport.
So okay, so if a mother, kind of just walk me through this. If a mother and father know that their baby has one of these conditions, walk me through what happens. Do you tell them, okay, we need to have surgery, or what kind of walk me through what happens, and does the baby stay in the hospital for a certain length of time after the procedures?
Sure. So typically most children with clefts, unless they have some other comorbidity or some other issue, which most of them don't, can be discharged within a day or two from the hospital. Mm-hmm. There's a couple of really nice special bottles that we use, feeders that we use to help them feed, and most of the nurses in the NICU or in the nursery are very familiar with those, and there's a couple that we recommend that they use that makes it a little easier for them to suck. If you can imagine, if you can't get your lips all the way around the nipple on the feeder, then it becomes an issue. So there's these little squeezable bottles and different things that they can use. But also a great question that they always ask is, for some reason they say, well, you know, can we breastfeed our child? You know? And the reality is, yes, you can. But of course, since they don't have a very good seal, in many instances the kid will get tuckered out pretty quickly. So they can obviously pump their breast and then give it to them in that, so they can still get their formula or still get the breast milk that way. So these are the things that we're able to capture ahead of time and explain to the families. When we do the surgery, it's typically when they're 4 or 5 months of age, as I mentioned before, in that range, and they will spend 1 or 2 nights in the hospital with that surgery.
Okay.
Yeah.
Wow.
So I know it's a lot of information, but we're very
well, it's good information that people should know about, and I appreciate you explaining all this. It's just stuff that I haven't thought about. I've heard of cleft lip and cleft palate, but I appreciate you explaining that, and yeah, I'm so glad to have you on today. So
it's my honor to be here.
Absolutely, and I just want to continue to bring awareness to this topic for sure. So thank you so much for coming on today once again, and share your contact with everybody out there one more time.
If they just call the Williston Health System and ask for Dr. Ghali or for the Department of Oral and Maxillofacial Surgery, they'll be put into our clinic, and they'll be able to speak with one of my assistants there.
All right. Well, thank you so much, Dr. Ghali. Appreciate it. And thank you guys for watching Healthline 3, and join us once again next week. That's when we'll have another Healthline. Thank you so much.